session.
Okay. So first of all, good evening, everyone. And thank you, chairpersons and organizers, for giving me this opportunity to present this topic. Although this topic is not a basic topic for us, but as radiation oncologists, we should be aware of all the new happenings that are happening around us in day-to-day practice. So this is, and in next few minutes, I would like to cover the role of PARP inhibitors in metastatic prostate cancer. So as we all know, prostate cancer is one of the commonest cancer that we see in males, and the reported incidence is increasing year by year, and almost all the patients of prostate cancer ultimately reaches a stage where they become castrate resistant or hormonal resistant. And overall prognosis of the prostate cancer cases at this stage is not very good, and the expected survival is around a year or two. So as I said, the prostate cancer moves from the localized stage to the non-metastatic stage and later to the metastatic stage. And in metastatic stage, it may be hormone sensitive or it may be hormone resistant. So hormone resistant metastatic prostate cancer is the topic for today, and how PARP inhibitors act in it, that we are going to see in next few slides. Metastatic prostate cancer is biologically heterogeneous. That means that it has been seen that there are multiple genetic pathways that are aberrant in these cases. So it has been seen that around 90% of metastatic CRPC patients have one or another genomically aberrant pathway involving cell cycle, DNA signaling, DNA damage, repair, and all. And out of these 90% patients, there are 23% patients in which the mutations lie in the DNA repair pathways. That means the DNA repair mechanism is faulty in these cases. And these are the patients in which PARP inhibitors have a role to play. As I said, when DNA is replicating, there are two types of problems that can happen. One is the single strand damage, which are generally repaired by base excision repair method, and another is the double strand breaks. And for that there is a mechanism that is called homologous recombination repair, or HRR. So sometimes there is a DNA, there is a single strand breaks, or sometimes there is a double strand breaks. But both of these type of problems have a repair mechanism, and a healthy cell has that repair mechanism in place. But if there is some problem in that repair mechanism, then ultimately cell has to die. So many studies, retrospective studies have been done in past, and that have shown that in those cases, in those metastatic CRPC cases, where there is some issue with the genes that help in repair, that is the most common genes are the BRCA genes. So it has been seen that those CRPC cases which have BRCA gene mutations, they generally have large tumor size, they have more aggressive disease, they have more involvement of nodes, they have more chances of metastasis, and they have higher Gleason score. So in nutshell, we can say that when BRCA1 or BRCA2 type mutations are present, the disease is more aggressive, and we have to choose more aggressive treatments also. So NCCN guidelines also acknowledges this fact, and they have recently supported that in patients who have a strong family history or who have high risk disease or very high risk disease, these patients should undergo germline testing so that we can understand the genetic cause behind the disease, and we can do appropriate prognostication and treatment in these cases. Now coming to the PARP inhibitors, basically PARP is an enzyme that helps in the DNA damage repair. So that is a routine enzyme that is present in our cells naturally. And PARP inhibitors are those agents that inhibit this enzyme from working or from repairing the DNA damage. So in presence of certain gene mutations, for example, BRCA1 or BRCA2, if these mutations are already present, then when these two situations happens concurrently, it leads to complete stoppage of DNA repair and the cells gets dead. So for example, we can say the BRCA1 or BRCA2 mutation act as a loaded gun, and PARP inhibition act as the trigger for that. And ultimately there is a shot and then the cell dies. So the mechanism of action is that PARP inhibitors inhibit PARP, which leads to single-stranded breaks, which are not corrected. So there is a single-strand breaks, and because these cells are already BRCA1 or BRCA2 deficient, so in them double-stranded breaks are also not getting repaired. So ultimately, the replication fork is stalled, and there is a double-strand break, and ultimately the cancer cell dies. Additionally, PARP inhibitors can also cause DNA damage repair mechanism inhibition by obstructing other ways of PARP enzyme functioning, and thus the replication gets stopped. So this whole mechanism was understood first in 2005, and after that, the PARP inhibitors came into being. So FDA, by now, FDA has approved or it is investigating these various agents. These agents are either olaparib, these are rucaparib, niraparib, talazoparib, and veliparib, and so on. So olaparib was the first PARP inhibitor that was investigated in 2009. So initially it was investigated in ovarian and breast cancer, but when good response was seen, it was also considered for other cancers like pancreatic cancer and prostate cancer. The ability to trap PARP varies between different PARP inhibitors, with talazoparib being considered the most potent agent among all these 4-5 agents. And the toxicity which they have is generally the hematological dyscrasias, including anemia, thrombocytopenia, neutropenia, anemia being the commonest. And apart from that, they sometimes cause GI toxicity like nausea, anorexia, sometimes creatinine elevation. And there is a concern that these agents also cause myelodysplastic syndrome and AML in few patients. So olaparib, as I said, it is the one of the most widely studied PARP inhibitor, and this was studied in few phase 2 trials initially, where it was seen that the patients who have homologous recombination repair alterations, means BRCA1 or BRCA2 types mutations, they showed very good response of in the tune of 88% when olaparib was given, as compared to the response rate of 6% in standard cases. So after these phase 2 trials showing good results, further developments were made in this direction, and then came the PROfound trial. The PROfound trial is one of the pivotal trial that has recently been completed, and it has shown a way to further studies on this particular agent. This was a phase 3 trial in which patients were initially divided into two cohorts. One was in which there was a BRCA1, BRCA2 or ATM mutation was present, and there was another cohort in which other 12 other type of mutations were present. And then these patients were either started on olaparib, that is 300 milligram twice daily in the form of tablet, or physician's choice of agents like enzalutamide and abiraterone. So ultimately, there were four arms, and the primary objective of the trial was to assess the radiographic progression-free survival. So this was the primary endpoint or primary objective, and the secondary endpoints were objective response rate, whether it was image-based complete response or partial response, time to pain progression, overall survival, PSA 50 response, that is at least 50% reduction in the PSA level, and reduction in the number of circulating tumor cells, which was defined as cells decreasing from more than 5 cells per 7.5 ml of whole blood. So when this trial was completed, this trial was completed very fast, in a very fast manner, and it showed that profound trial met its primary endpoint, and it shows that in the cohort A, the progression-free survival was 7.4 months in the arm in which olaparib was given, while it was 3.6 months in the other arm, that is, you can say, control arm. So there was about double of the progression-free survival. Likewise, the arm which had BRCA1 or 2 mutations, that with olaparib, it shows 33% overall response. And while the other arm, with the standard treatment, it shows only 2.3% of objective response. Similarly, when overall survival was assessed, the overall survival was again better in the olaparib arm, and as compared to the standard arm, though it was not significant, but still it was better. PSA 50 was again better in olaparib arm, that is 43%. In 43% cases, there was a reduction in PSA level, more than 50%. In other arm, it was 7.8%. And circulating tumor cell reduction was found in 29% in olaparib, while 11% in the standard treatment arm. When when there was an overall analysis using BRCA1, BRCA2 cohort and the other mutation cohort, then also the progression-free survival was better in the olaparib arm. As far as adverse event profile was concerned, anemia and nausea and fatigue was the commonest, and but there was no reports of myelodysplastic syndrome or AML as it was thought of initially. So PROFOUND was the first major study that showed improvement in overall survival and radiologically progression-free survival with PARP inhibitors in metastatic CRPC cases, though the OS was not statistically significant. Further benefit was probably obscured because 80% of the patients were crossed over to the olaparib arm once they progressed on the standard therapy. And olaparib was also associated with better secondary endpoints in the olaparib arm. And this trial finally led FDA to permit olaparib for use in clinical practice in metastatic CRPC. After that, few combination strategies are being studied with PARP inhibitors and some other agents. One is the combination of PARP inhibitors with androgen therapy, in which olaparib has been combined with abiraterone as a first-line therapy in metastatic CRPC. And a phase 3 trial is being done where niraparib and abiraterone are being studied in the patients with HRR alterations. So these are few studies. They may further show us whether androgen therapy and PARP inhibitors can be combined. Few studies have been done which have studied the combination with immunotherapy, and it is based on the rationale that DNA damage once happen in the body, it leads to immune activation. So immunotherapy may be working better when PARP inhibitors are combined. So there are two trials, Keynote 365 and Keylink 010, that are studying pembrolizumab or with olaparib or with olaparib versus abiraterone. So they may further show us the way to go further. Then there are combination with cytotoxic chemotherapy, but there is a concern that chemotherapy and PARP inhibitors may be too toxic for the patient. So this combination is actually not being developed any further. And last but not the least, there's an excitement about combining PARP inhibitors with ionizing radiation. And if they are found to be working, then they may act as a radiosensitizer agent also in future. But these data have few limitations. The first is that the few studies that has been done, they all are using different primary outcomes and different endpoints. So it makes difficult to interpret the results. Many studies have been published mostly as the interim results, and there are only few studies which are phase 3. So we'll have to really wait for more clarity on PARP inhibitors' role. Moreover, a wide variety of definition of HRD genes. There are so many genes, and we really don't know their significance. Only BRCA1, BRCA2, and ATM are the genes that have been widely studied. So we have to understand these genes first in a better way to understand PARP inhibitors. Moreover, olaparib and rucaparib has been approved, but by only FDA. So the status of their use is not known in other part of the world. And there are no phase 3 studies for the combinations which I discussed. Only phase 2 studies have been done. So we need more phase 3 studies for combining PARP inhibitors with the agents like immunotherapy and radiotherapy. So in summary, I can say that PARP inhibitors induce cytotoxicity through a novel mechanism that is called synthetic lethality in the appropriate genetic background. The appropriate genetic background is very important prerequisite in their case. PARP inhibitors are effective in multiple tumor types with underlying HRD genetic alterations, specifically BRCA1 and BRCA2 mutations. FDA has approved olaparib for metastatic CRPC patients with somatic or germline mutations, and it has progressed through enzalutamide and abiraterone. There is a need to understand further biomarkers because we still do not know how to assess the response of PARP inhibitors. And upcoming data from the ongoing trials will help us to clarify the role of immunotherapy, radiotherapy, and androgen deprivation therapy, whether they can be combined with PARP inhibitors. And it will be interesting to explore their role in earlier stage disease rather than metastatic disease in a more radical setting like neoadjuvant or adjuvant settings. So with this, I thank and I hope that I made some clear message regarding PARP inhibitors. Thank you.